Next presentation is from Dimitrios Doudesis, and Dimitrios is presenting on the machine learning to optimize cardiac troponin for the diagnosis of myocardial infarction. Dimitrios from University of Edinburgh.
Hello, it's my honor to present here today. My name is Dimitrios. I just completed the PhD at the University of Edinburgh in precision medicine, and this is some findings from my PhD. Acute myocardial infarction, the problem, most of you, probably all of you will be aware that's probably the most common problem, and over 1 million of patients present in the medicine department every year in the United Kingdom, which accounts for around 5% of all attendees overall. However, only 1 in 10 patients actually have acute coronary syndrome, and the whole process and the whole assessment costs to the NHS around £1 billion. Now, the challenge is that the guidelines recommend fixed cardiac troponin thresholds for the assessment of patients with suspected acute coronary syndrome. However, these approaches rely on thresholds that do not acknowledge that cardiac troponin is a continuous measure and varies within individuals. As a result, performance varies in important patient subgroups as concentrations are influenced by age, sex, and comorbidities. This limitation can be addressed using machine learning algorithms. But first, extensive literature has shown that all diagnostic thresholds are actually a compromise, and publication in the top 4 general medicine journals shows that if you try to select one single threshold that will supposed to work for everybody, you will lose in terms of sensitivity and specificity. So what we did first was to evaluate 2 of the suggested rule-out thresholds, the less than 2 and less than 5, and to show that actually, although they perform quite well in terms of safety, there was some subgroup heterogeneous performance, and when it comes to proportion and efficacy, these suffered as they cannot apply to early presenters or patients with ischemia on ECG. And yeah, we did the same thing for ruling out myocardial infarction, and the sex-specific 99 percentile, along with the recently introduced 64 as the ruling threshold, performed quite poorly, again being quite heterogeneous across almost every subgroup, and again the proportion were not great. So what we did was to create CoDCS. So CoDCS stands for Collaboration for the Diagnosis and Evaluation of Acute Coronary Syndrome. And to develop that, we used the high-stake registry in Scotland, led by Professor Nicholas Mills. And we use information from over 10,000 patients with a median age of 70 years and 52% being male. For the model development, we actually combined the baseline characteristic of of each patient, such as age, sex, previous medical history, variables from the clinical examination, such as their heart rate, systolic pressure, and of course troponin, along with eGFR and hemoglobin, to compute CoDCS. CoDCS is a machine learning model that computes a score from 0 to 100 that corresponds to that particular patient having type 1 myocardial infarction. We then moved to externally validate the model in over 10,000 patients from 7 cohorts around 6 countries all over the world, with a median age of 60 years and 65% being men. Overall, the model in the external validation performed quite well, achieving an area under the care of 0.95, while the calibration was great across the whole range of the score. You can see here. So what else we did was like, how would CoDCS would perform in clinical practice if it was going to be applied as a pathway. So the idea of the pathway is that if you're getting a CoDCS score of less than 3, then you've been ruled out. If you're getting a CoDCS score of greater than 60, then you've been ruled in for the diagnosis of myocardial infarction. And of course, this leaves the middle group. So at presentation and with the use of only one single measurement, troponin measurement, CoDCS managed to rule out 61% of patients with an excellent sensitivity of 98% and a negative predictive value of 99.6%, while it ruled in 10% of patients with a specificity of 97% and a positive predictive value of 75%. That leaves 29% in the observed zone, but remember we are at presentation, so what most guidelines recommend is the measure of troponin in another yet flexible or flexible time point. This can be 1, 2, or 3 hours. So after incorporating the second the serial measurement to the CoDCS model, we managed to further rule out 11% of patients, again with excellent sensitivity and negative predictive value, while we ruled in an extra 5%, again achieving quite high performance. Overall, then in these 10,000 patients from all over the world in the external validation, we ruled out safely 72% of patients, which in the paper we compare that with like the other approaches, and in terms of efficacy we have greater numbers, but also we rule in 15% of patients with quite high accuracy. And yeah, we have some patients in the middle. This is the 13%, which they need some further assessment. This is the subgroup performance of our model in the external validation, where we have consistent performance across almost all subgroups, both for NPV and PPV. And although we created a diagnostic model, it was very important to see how the outcomes of this patient that falls into each of the three categories perform. So we can see that both for cardiac death as an outcome, but also all-cause death, patients that have been sent home from the emergency department, they don't die from any cause or cardiac-related causes. However, both patients that have been identified as high probability by the algorithm actually tend to have these kind of deaths over the following year. And we think that it's interesting that the cardiac death group here, the middle group, it's different with the all-cause death, which probably highlights that maybe even if these patients are not in the immediate risk of having an MI, but there are probably something wrong with their health and probably should be assessed and not being sent home straight away from the emergency department. Now, what else we did was actually to create an actual prototype app that you can access from your mobile phone or from your desktop. And I'm going to press play now. And yeah, a 60 years old female with no chest pain, 8 hours of symptoms, highly elevated heart rate, systolic pressure, no ischemia, with hyperlipidemia, eGFR values, normal kidney function, hemoglobin of, I remember, 12, and troponin of 10. We click submit and we get the individualized probability for that particular patient, along with the diagnostic metrics of negative predictive value, positive predictive value, sensitivity, specificity. And to sum up, the CoDCS score can rule out and rule in patient with a single measurement troponin, while some other diagnostic algorithms that are out there require the use of 2 in order to give a probability. As you can see, can provide individual diagnostic metrics for patient in the observed zone, in addition to what the ESC pathway, for example, suggests, where like if you're in the middle, you're in the middle, and you can get an idea of like how in danger this patient is, and it can further rule out patient from the observed zone at presentation with the use of serial measurement, have a quite homogeneous performance, and last but not least, both the algorithms and in the app, we have added the functionality that allows each different hospital to set their own diagnostic rule out and rule in performance criteria. For example, we know in the US, they have quite high the bar in terms of like safety, but in other countries, this might be a bit lower, or it can be depends on the resources of each hospital. So it is not fixed, each hospital, which the user is that the hospital can adjust that. I would like to thank the founders and the CoDCS research team, and I'm happy to take any questions. Thank you very much.
Can you just quantify for me how you established the diagnosis of myocardial infarction in the patient?
Yeah, so this was double adjudicated from a senior clinician that they had access to all the patient information, and if there was disagreement, there was a third consultant cardiologist that were acting as a referee.
Not based on troponin levels, only.
No, they had access to, so the diagnosis, for example, for the model development, we used the high stakes trial. This assessed the introduction of high sensitivity assays. So the diagnosis was made based on the high sensitivity troponin measurement, but also its cardiologists had available information, like retrospectively, like after the patient has been discharged and evaluated, they had access to everything. So we did that to improve the diagnosis that is being made in the hospitals.
What are your plans to take this forward next?
Yeah, that's a great question. We're currently in the process of actually trying to implement that, and we recently changed from troponin I to troponin T in the NHS Lothian. So this was trained based on troponin I measurements. So we're currently collecting patient information for troponin T, and we're working towards an implementation and an randomized clinical trial.